Yeah, and
Thank you.
invite Luciano to talk about conservative observation.
Yeah. Just a moment. Okay. I would like. Can you see my presentation now? My slide? Could you see my slide?
Yeah.
Yes, Luciano, you can go ahead.
Sorry.
Perfect.
Good morning. It's a pleasure and an honor to be invited. Thanks a lot for this kind of invitation. So I would like to start just with this sentence. So if we have Symfurter, it is by the standing on the shoulder of giants. Why? Why? Because I would like to remember two people died in the last year. One is Taka Fukushima, my mentor for many years. And after meeting him, my life changed completely and my professional life changed 100%. And thanks to him for all my life. And then a few days ago, we lost another giant, Professor Dolenk, and I had the opportunity to meet him many times in cadaver labs and in meetings, and it was always a great experience to meeting him and learning by him. So thanks a lot to these giants for my the professional life of many of us. So this is my hospital, and the Department of Neurosurgery is indicated by the arrow. The topic of this presentation is the management strategy of vestibular schwannomas between observation and intervention. Nothing to disclose. At first, as we've seen in the previous lecture, the anatomy is fundamental for the comprehension and the understanding of the pathology of the CP angle. It's a complex anatomy, and we have to learn it in the cadaver labs times and times. It's not easy to understand immediately at first steps. Which is the goal of the modern management of vestibular schwannoma? First, remove the tumor, of course, but control the tumor is another possibility. Then we have at first improve the quality of life, preserve the neurological conditions, mortality and morbidity as low as possible. And all these goals are in relation to tumor size, growth pattern, patient's age, symptoms, and comorbidities, sorry. And we have the opportunity to treat them with three main options. At first, a conservative therapy with watchful waiting, radiation therapy like stereotactic radiosurgery, and surgery. When we should watchful waiting and control patients with MRI in the ear. At first, incidentally diagnosed vestibular schwannomas. Then we find a small sites. When we recognize in serial MRI the low growth rate, less than 2 millimeters per year. Then patient with a bad hearing or no hearing in absence of neurological symptoms, especially trigeminal or other nerves. Some authors include the small intrameatal vestibular schwannomas in young patients with serviceable hearing, so with a usable hearing, among the patients that have to be observed during the years. This is because of the possible higher tendency to remain stable, according to them. But if we follow the CNS guidelines of 2018, younger patients who still retain a hearing function should be treated with hearing preservation surgery. This could be the best option for them. This is the flow chart of the wait scan, wait and see strategy policy. And as we can see, we have, of course, these strategies in the stable small tumors without symptoms. But we can follow this strategy also when we remove partially, subtotally, the tumors in hearing preserved cases. And then we have to decide what to do. If the tumor is not stable, we can wait and scan again. If the tumor is growing, we can decide for surgery on radiotherapy in relation to many factors. When we apply the microneurosurgical strategy, at first in patients with socially useful hearing for possible hearing preservation, this of course is debatable with our radio surgery stereotactic surgeons colleagues. When the size is over the 2 or 2.5 centimeters, with exception of small tumors for hearing preservation, of course, including the intracanalicular ones. When the growth rate is higher than 2 millimeters per year, in cases of neurological symptoms, especially vestibular schwannoma-induced trigeminal neuralgia, and in cases of cystic degeneration on MRI. Therefore, the patients under 65 in good clinical conditions seems to be the ideal candidates for microsurgical removal of tumor, according to the CNS guidelines. And this is another flowchart according to the level of hearing. If we have a good hearing, we can propose, and small tumors, of course, we can propose surgery, and we can have a total removal, and then we do the follow-up. In some cases, we cannot for adherence, and we do subtotal, and then wait a scan, and then in relation to the behavior of the remnant, we can decide for surgery or radiotherapy. In patient without a good hearing, if the tumor is small, we can wait and scan, of course, if the tumor is stable and no symptoms. But if it's growing, we can decide according to the general condition of patient and the age and other factors, if go on and treat him or her with surgery and radiotherapy. Of course, no chance for the large and in case cystic vestibular schwannoma, surgery is the first indication. This is our algorithm. The algorithm we follow, we have a diagnosis of vestibular schwannoma that it's very close to the IANO guidelines suggestions. And more or less is the summary of the previous table I showed before. And of course, the active treatment is in relation of many factors. Sometimes you can decide to do surgery. Sometimes we can decide to do radiosurgery. Especially when we have patients in the 8th decade of life. You know that nowadays it's very easy to have patients 70 or more with a diagnosis of vestibular schwannoma. What to do? Of course, if the tumor is small, mostly we have to wait and scan. In case of growing of tumor, we can decide seldomly in very good conditions to do surgery, but in majority of cases, if the tumor is growing and the patient is not in very good conditions, better to do stereotactic radiosurgery if it's not possible to wait a scan. In cases of large tumor with symptoms, ataxia and other symptoms, we should do something, of course, and we have to do a judicious debulking, removal of tumor, subtotal removal in many cases, and wait and scan if tumor is not growing. But if this residual of tumor start to grow again, better probably to do stereotactic radiosurgery. As we know, we have several surgical approaches. The retrosigmoid, used in majority of cases. Personally, I use all time since 10 years this kind of approach in small, large vestibular schwannomas, of course, for hearing preservation. But we have also the translabyrinthine approach, indicated mostly for deaf and old patients with large tumors. And we could approach it also by the middle fossa, of course, for small tumors, small intracanalicular tumors for possible hearing preservation. But I started to do it in the beginning, but I stopped it because the retrosigmoid for me is much more comfortable, according to the teaching of Fukushima. Shortly, this is our surgical series. We had 400 consecutive cases. And the majority of them were grade 3 or grade 4 according to the cause classification. Strangely, but the bigger sides we observed in the younger patients, the facial function results were quite good in HB1 or HB2 in more than 90% of cases, especially where the facial nerve was ventral superior or ventral inferior in relation to the capsule of the tumor in the CP angle. we could preserve the hearing in around 60% of cases when the size was less than 2 centimeters and the pre-op hearing was good. So in any case, we use a complete intraoperative monitoring of many functions. I skip this, is very clear. And these are the key points we follow any time: the lateral Fukushima position, keyhole opening and micro technique, the CSF aspiration from the lateral medullary system. We try to be clean, bloodless, sharp, maintaining all time as much as possible the arachnoid plane, and do a very large debulking in internal of the tumor. So identification of facial nerve monopolar stimulation and the capsule elevation, taking account to preserve any artery and any vein, especially the petrosal vein. And so in summary, we had zero mortality. The blood loss was very small, very low. The facial nerve function was HB1 in around 80%, HB2 in around 15% of cases of follow-up. The social useful hearing, as told before, is around 50% when the pre-op hearing was good. Mean operating time around 5 hours, permanent cerebellar dysfunction in only 3 cases, but transient vertigo and vestibular symptoms in 1 out of 5 cases, but transient and a few weeks on maximum. The facial nerve localization is one of the key points of our surgery, of the surgery of any vestibular schwannoma neurosurgeon and surgeon. And in a series of 100 cases, we locate the facial nerve in about 50% of cases in the anterior superior position, I mean the classical position of facial nerve. In 1/3 of cases, it was ventral, so on the opposite side of our view, and in 21%, I mean 1/5 of the cases in anterior inferior position. In the whole series, in all 400 cases, we had only 3 cases of dorsal location, I mean immediately in front of us when we open, and this is the worst condition and the terrible condition. We tried recently to see the possible use of the fluorescein and during the acoustic schwannoma surgery, and we found that it could be some useful in order to distinguish better the position of facial nerve confirming our neurophysiological probe. And usually the nerve is pinky in comparison to the tumor that is green. It takes normally a lot of fluorescein. And the pink area is the nerve, usually the facial nerve confirmed by stimulation. And it's another way to be safe that the nerve is there and we can go on with the removal of it. Essential for the total removal of tumor is also the removal of the portion inside the internal acoustic canal. And for doing this, since around 10 years now, we use the endoscopic assisted microneurosurgery. At the beginning, we did with a flexible endoscope, and I go faster here. And when finished with the microscope, the removal of tumor, we were, oh my God, and we were almost sure to remove everything. The flexible endoscope in this case showed again tumor in the fundus, and then we could improve our removal and obtain a total removal. Now, since around 1 year, we have this other device that is probably a little bit more beautiful in terms of quality and useful in terms of confirmation of total removal of the tumor. This is the final view, 2 cases with confirmation of the function. The results in small tumors are very encouraging and very good. So this is the reason, because we prefer, especially young patients with no comorbidities, with good general conditions, to go and treat them with surgery. Because at the final follow-up, the facial nerve result was HB1 at the follow-up in 97% of cases. This is a review of 100 consecutive cases. The hearing preservation rate was more than 60%, total removal in 98% of cases. We had transient complications like CSF leak or some other transient problems, but in 8% of cases. Permanent complications, 0, mortality 0, only 2 recurrences after this subtotal removal, treated with resurgery in one case and radiotherapy in another one. So in small vestibular schwannoma, the results in terms of facial nerve, hearing preservation, and removal are very encouraging. Different topic are the large vestibular schwannoma. Of course, it's a little bit more complex. The general and the bulking of tumor is a fundamental step. This is our review. There's another review we did with Professor Martin Samiš from Czech Republic. We joined our experiences in this other article, and we found that the capsule was adherent, very adherent to tumors in more than 60% of cases. And hypervascular tumor we observed around 60%. Detail, but very interesting, is that the patients with trigeminal symptoms had better facial nerve results, probably because in the majority of them, the positioning of the facial nerve was in the anterior superior and anterior inferior position, and this was associated with the better facial nerve results in comparison to patients without trigeminal symptoms, in which the distribution of the facial nerve was 50-50. Probably this is to put in correlation with the different growth of the tumor. When the patient has a polar, when the tumor has a polar growth, it's possible that it arrive close to the trigeminal root entry zone, displace the arachnoid, and duplicate the arachnoid on the facial nerve, but eliminate the arachnoid protection of the trigeminal nerve at the root entry zone, responsible of the possible trigeminal symptoms of the patient. This is, of course, to be demonstrated, but this is our explanation of this. For facial nerve preservation, time to time, we can decide to leave millimetric residual capsule, especially attached to the brainstem or to the facial nerve. And in this case, the final result could be very, very exciting for the patient and for the surgeon too. I'm approaching to conclude this presentation, but I would like to show you that in a majority of cases, majority of surgeons approach vestibular schwannoma, the first question I have in my mind is, where is the facial nerve? Just before surgery, also we try to understand where is the facial nerve according to the MRI we have at disposition. But we know that the MRI DTI is could be useful, but it's not always available in any department, in any hospital, and the adherence to intraoperative anatomy is not always clear, and not yet confirmed a positive effect on facial nerve outcomes. So I tried to change to another way to understand this, and change the question to me. It's possible to predict the vestibular nerve of origin of any vestibular schwannoma, and then understand, according to this data, which is the course of facial nerve, and optimize the surgical strategy and the results. Starting from 2020, we started to cooperate with our ENTs with some tests, especially the vestibular evoked motor potentials and the caloric stimulation. The VEMS are clinical tests for the inferior vestibular nerve, the caloric stimulation for the superior vestibular nerve. In relation to the effect of these two tests, we can understand which is the nerve of origin, the nerve damaged by the growth of the tumor. And we try to put in correlation with the positioning of the facial nerve in the CP angle. We know that the anterior superior and anterior inferior position is the best in terms of facial nerve results. And we found that in tumors originating from the superior vestibular nerve, in the 59% of cases, the facial nerve was ventral, so in the most difficult position. In the inferior vestibular nerve schwannomas, the facial nerve was polar in close to 90% of cases. In 106 cases, we evaluated with this study until June 2024, so we have 6 months of follow-up. We understand that the knowledge of the nerve of origin of tumor is useful in terms of facial nerve result, and both in the early post-op evaluation and mostly at the 6-month follow-up. So knowing the position of the facial nerve according to the knowledge of the nerve of origin of the tumor seems to be useful. And there are some differences in between superior and inferior vestibular nerve in terms of result, not in the early post-op facial nerve function, but at 6-month follow-up, the tumors originating from the inferior vestibular nerve has a better facial nerve outcome. It seems that the majority of ladies has an origin of tumor originating from the inferior vestibular schwannoma. And again, trigeminal neuropathy is more common in superior vestibular nerve schwannomas for the position, of course, close to the tumor. In our experience, limited experience, no differences for the hearing preservation. So in conclusion, usually vestibular schwannoma, in my opinion, requires surgery, but we have a space for wait and scan in small and not growing vestibular schwannomas, especially in old and deaf patients. Of course, there are spaces for the stereotactic radiosurgery too, we will see later. So the total removal is possible, preserving the facial nerve, and in some selected cases, also preserving the useful hearing, social useful hearing, especially if the tumor is small. And then microsurgery can cure vestibular schwannoma. This is the most important point. In addition, preoperative trigeminal symptoms seems to be associated with better facial nerve function, and the vestibular nerve of origin of the tumor seems to be associated with the facial nerve outcome. In particular, inferior vestibular nerve schwannomas seems to have a better facial nerve result. Thank you for your attention.
Thank you, Luciano. Nice. And could you, Sabino,